Yes. I'll wake everybody up here. So I hope nobody actually has a seizure disorder, because this could induce it. Okay. So talking about, I'm talking about primary brain tumors, secondary being brain metastases, and then one of the results of that being seizures. So brain mets are more common than primaries, and the probability of developing brain mets depends on the type of cancer you have. So you probably remember Buy the Kid Long Pants. And then some are very rare. So prostate rarely goes to brain. So sometimes that's helpful to know, because if you're seeing somebody and they're having headache, but if you have that sense of how likely or not likely the cancer is, that can help you. It's found in about 10% of cancer patients, but the incidence is actually increasing, and that's because we're treating more, right? We're coming up with better and better anti-cancer treatments, and so people are living longer, and so have more time to develop brain metastases. Now, if you discover them and their performance status is poor, and it's decided that they're only going to be treated with dexamethasone, the median survival is 1 to 2 months. If they have whole brain radiation, it's 3 to 6 months. And for some populations, it really depends on their performance status before, and looking at specific factors, because some people can live much longer than that too. Just briefly about primary brain tumors, they arise from various different types of brain cells. About a third are malignant. They represent only about 2% of cancers, but they do have a high mortality rate. The two most common are anaplastic astrocytoma and glioblastoma, and they have poor prognosis, and this has changed very little. We haven't done much to change that over the last number of years. So brain tumors can lead to headaches, focal neurological deficits, cognitive dysfunction, seizures, stroke. So to look at management, it really is based on two things. So number one, the control of the edema and any increased intracranial pressure with steroids. And dexamethasone is the drug of choice. It's considered the steroid with the least mineralocorticoid effect, so less fluid retention, so that's why it's picked. The starting dose for severe symptoms is usually 10 to 16 milligrams, and then 8 twice a day if severe symptoms. You will see the radiation oncologist order it QID. It doesn't need to be, it has a long half-life. On the other hand, we say twice a day, morning and noon usually, because we think it interrupts sleep, so I guess we're assuming that there is a little bit of a drop-off. We try to get somebody weaned off because of the side effects as much as possible. So if you start them at that because of their symptoms, but then you would try to titrate back down and see what their symptoms are. People probably have a good sense of the side effects, the Cushingoid features, the gastric ulcers, bone thinning over time if you're looking at a longer prognosis. Also, some psychiatric that can agitate people, and as we said, insomnia. So the lower doses, the better. It has good absorption from oral route, so that's usually good enough. You don't usually have to get it into them IV. It'll start working within a couple hours, and they have maximum benefit within 24 to 72 hours. And then the other issue would be the treatment and prevention of seizures. Okay, so then a little bit about seizures. So they're less common in people that have metastatic lesions as opposed to primary brain tumors, at least according to the literature, so 25% compared to more of 50 or above. Interesting, I thought that the type of cancer matters. So melanoma, if it spreads to the brain, is much more likely to cause seizures than, say, if it's from lung or breast. I don't know why. Seizures represent a significant source of morbidity, so you really do need to look at what they're on and treat accordingly. So just a step back, that even though we've been talking about the different types of brain tumors, I mean, there are other causes, obviously, of seizures at end of life. And the first thing you want to do is make sure you're actually talking about a seizure and not twitching or myoclonus that you might be getting from something else, including opioids. The brain tumors, as we mentioned, but obviously metabolic causes, hypoglycemia being one that probably should still be checked even in a hospice setting, because you still have people on hypoglycemics, so that might be worth looking at. Drug toxicity, Alzheimer's disease, drug withdrawal, encephalopathy. So if a patient has had a seizure then they're started on an anti-seizure med. So it's not done prophylactically for patients with brain tumors. Except for possibly with melanoma, because it's so common that apparently some physicians will start them. Now, newer agents are generally preferred because of their better safety profile and less drug-drug interactions, so your Kepras and your pregabalin. I mean, to be honest, I don't start these on people. I don't tend to see people where I'm starting them. They've come already on these things. So if they have a seizure while they're on a medication, then you'd be looking at their other meds to see, did I lower their seizure threshold somehow? Are they having withdrawal from some other medication or from alcohol that's contributing to this? I need to look at the level, potentially, if it's something like Dilantin. And again, remembering goals of care and where we're at. Were we weaning down the steroid dose? And that's what we've done. We've caused more edema again, and we just need to go back up on the steroid dose. So those would be things you'd be thinking about. So then, if we're talking about sort of the more hospice patients in their last weeks of life, I guess the way I would be looking at it is they're going to stay on their anti-seizure medication that they have, that presumably because they've already had a seizure, that would be the only reason they'd already be on one. And they would take that as long as they can take their oral meds. That makes sense. And then at some point, they're going to lose the ability to swallow. That's the expected course, the trajectory of dying patients. They have fairly long half-life, so it might be okay just to not do anything, depending on how you feel things are happening. But sometimes, they lose their ability to swallow, but you still think they're going to have a while. Then you might, and if they've had a severe history of seizure or they've had a lot of problems with them, then I would probably be looking at putting them on maybe some subcutaneous phenobarb, or sometimes you put them on a low-dose benzodiazepine just to kind of buy yourself a little bit of change in the seizure threshold there. And of course, you'd always want to have covering orders for benzodiazepines to be available as a PRN, especially so if you're talking about your home patients that are dying at home, it's something you need to talk to the family and have a plan with the home care nurse and the family. How are they going to do this? It'd be interesting to talk maybe with the other physicians after how they normally do. I mean, I usually just stick with Ativan, and because it is sublingual, but you can make a slurry up and kind of have it in a syringe and give it to them. I mean, most of the time, by the time the family goes and gets the medication, the seizure's stopped. But to have something in case there was a more protracted seizure is a good idea. Or even after the seizures happen, they've given them the Ativan now, and then you've made it less likely that they'll have a repeat one. And I think it always makes people feel better that they have a plan and they're doing something and they're taking action. Okay, so if we look at the medications, from the literature, the lorazepam's really the drug of choice, but you will see other, you could use Valium or midazolam sometimes, but lorazepam's good because of the speed, the duration, and it can be given subcutaneously, sublingually, so it's got fair ease of administration. If you just have a simple partial seizure, 1 to 2 milligrams subling or sub-Q, and then as needed. If you have a more prolonged seizure, you could give higher doses, PRN. Again, looking at other agents if you need to, potentially phenobarb or something like midazolam. It's really rare to have somebody that has a more prolonged seizure in my experience, because these people are usually on steroids or they've had radiation. So, again, interesting to get some of the perspective of other people, but I've not, had to deal with a patient in status epilepticus that we couldn't resolve. Not that it never happens, but. Okay, so take-home meds. You only need anti-seizure medications once you've actually had a seizure. You don't need it prophylactically. It's just not evidence that that helps. And there's so many side effects from the medications that it's just not seen to be best practice. Seizures are fairly common though, and so you should have benzos available for in-home or hospice, obviously. You can convert an oral anti-seizure medication to injectable phenobarb when they're unable to swallow. And just a reminder that seizures are scary to patients and their families, so it's one more thing where you need to educate and address any concerns and sort of have a conversation around it. But I find it sort of like when you have the discussion around terminal bleed, it's more that's the hard part, is having the discussion and then usually there's no issue. Okay, so that wraps it up.
Thank you. I'm going to ask a question here. In the UK, I'm sorry to say in the UK, but in the UK, we were all brought up with the Sterzolid suppository, which is a diazepam suppository. There's nothing like that. Here we go.
I don't order it, then I don't know if we can get rectal diazepam easily, like something. Can you? Apparently you can.
Fantastic.
The compounding pharmacy on Memorial can just about put any drug in a suppository, including phenytoin. So it's a great way to go.
Right.
And I'm not sure if they can do that with quetiapine, but that's a really good one to use. So that would be I'll ask and find out. But that is available in Qualicum. Okay.
It was the mainstay certainly on the paediatric ward as well, was the good old Sterzolid rectal solution rather than the suppository. But anyway, thank you very much, Leah.